mostly we are doing cochlear implant surgeries and other types of auditory implants. Currently, we're just servicing the state, and it also just quickly speaks to the issues that we are struggling with, because we've actually had to do a cochlear implant for a patient in private, only one, but most of the patients have come to the state because of, the inequities in the service. So yes, those are the issues that we need to discuss. But further on, you contact the audiology department and the ENT department in Golazan for patients with hearing loss, and particularly profound hearing loss that would need cochlear implants. And we're very proud that the MEC did actually table the budget for our implants service, so that's great. So, again, I don't want to bore you, but I changed the topic to common ENT emergencies, because if I was going to talk about common ENT conditions, we're going to be here until tomorrow. Is this like the... Is it just the arrow? Okay. So really, the most commonest things that we find causing an urgent consult is foreign bodies, trauma, complications of the ENT infections, and mostly malignancies as well. Next slide. It's not moving. Of course, the ear is one of those incredible but very sensitive structures. We've always getting called about things in the ear, but I've realized that people in Zululand love their earbuds. Stop using that. Stop putting those things in here. It's the earbud, it's the chicken feather, it's a lot. Stop it. Matchstick, stop it. Those things actually cause infections, and I say this to patients. Number one, if you are thinking that you're helping me before your consultation by cleaning your ear, don't do it. I like dirty ears. Bring your wax with you, okay? First thing, you put your earbud in there, you push the wax deep inside, and the fact is this, wax is actually there to clean your ears, just like your tears, that they're cleaning the eyes, all right? So leave the wax alone, because it gets produced all the way in the ear canal, migrates out. So when you put your earbud, you're pushing it back. Now you're creating the impression in the ear that you've got another foreign body, so you get more wax production, and that gives you wax impaction. And from then on, with diabetic patients, you get otitis externa and then malignant otitis externa, which is actually quite bad. Last week, I think I've had to do extensive mastoid surgery for a patient who started with an earbud, and is a diabetic patient. So it's quite bad. Again, the concern really with the small children is small batteries, those watch batteries. Those are quite an urgent referral, because they leak, and you start getting chemical burns. And we've had a patient referred to us already with facial nerve paralysis because of chemical breakdown. And when I opened the ear, the entire facial nerve was broken down, all right, by the lithium. And also sensorineural hearing loss from that. So that child is actually waiting for a cochlear implant. So that's really bad. So that's an urgent referral. So all I'm interested in you telling me is that you've killed the insect with the water, all right? Because what will irritate the patient is the movement of the insect. And also the fact that if it's a battery that's urgent, nobody should be sleeping on it. Okay, I've mentioned those secondary complications, some of them, the ossicular chain disruption. Some of the patients would attempt to answer the phone with the earbud while it's still in there. And what do? I've had a patient who did that. More than the perforation, actually disrupted the entire ossicular chain and dislodged the stapes into the vestibule, and they had a dead ear. So a dead ear is when you're dizzy and you can't hear. Next slide. This is just a battery that's stuck in the ear, but you can see that there's already erosion going on here, all right? And this can happen within minutes, all right? Next slide. Next slide again. Again, that obviously mandates us to go to theater. And most of the time, when I've had to remove batteries, I've always ended up with a canal wall down mastectomy, which is like a 4 or 5 hours procedure, because you end up exposing the facial nerve. These are some of the things that you can have in your practice. Really, that will help if you feel that you are confident. One thing I always encourage, get yourself a headlamp, ENT headlamp. It gives you good vision if you really would like to to remove some objects that are really obvious. But if it's deep into the isthmus, into the ear canal, I advise that you actually refer it, because number one, it's mostly children who will not be able to be held down for you to remove the foreign body. And so that puts them at risk of you actually injuring the ear and causing those complications I've just mentioned. So generally, I prefer to take those children to theater and just remove those foreign bodies there. Okay. So these are some of the instrumentation you can have. Next slide. The rugby players, I don't know what is happening with the rugby players. Mostly I'm seeing those. This is an auricular hematoma, and I know your first knee-jerk reaction is to aspirate that. Please don't, all right? When you aspirate it, number one, you introduce infection. Number two, you're actually encouraging rapid recollection of the hematoma that's there. When we drain that, we drain it in theater, because then you have to put a very tight silicone sheath over this area to prevent it to recollect. So you want to just close that space. So generally, my makeshift silicone is actually a catheter to just suture it around there so that that whole entire surface is flat, because you don't want recollection. Next slide. Again, we've talking about this. Next slide, please. You know, this is one of those Shisampama outcomes. Please go back. Right, so Shisampama outcomes. But every week, recently we also just had a little girl that was playing basketball, and she had a whole ball hit her ear. Sometimes it's the rugby players. So that's a traumatic perforation, and that's quite a very painful injury, because the first thing that really happens is the rupture of that tympanic membrane. Now you've got about 4 nerves that are actually giving you sensation to that drum, and that's really painful, all right? And the second thing that you get is the actual barotrauma, which transmits immense amount of pressure into the vestibule, into the inner ear, and you then get dizzy immediately because you destabilize that vestibular pathway. You destabilize the hair cells, which are actually at risk of actually dying immediately. So that's why you get tinnitus with that, because those are the hair cells that get destabilized. And you only have 30,000 of them, and guess what? They can all die in that one hit, and you can have sensory or hearing loss, all right? So those patients, again, put them on steroids, okay? That's the first thing you do, because you want to really take away all that edema that actually gets, that they experience from the pressure. But the second thing also that you worry about here is the ossicular chain disruption that can happen there. Because obviously that would mean the patient will get conductive hearing loss that you need to address. And the third thing also is to exclude that there aren't any other fractures, because you can get temporal bone fractures with that, which we'll see in another slide. Usually these lesions, first of all, when you've managed the acute situation, which is the pain, the vertigo, which you will manage, number one, with the circ, all right, but also with the steroids, because the vertigo will come from the acute hydrops in the vestibular system, from the pressure, from the barotrauma. So steroids often help and rest the patient, sedate the vestibular system. Generally, Ativan and steroids would settle the patient. But the first approach for us would be a wait and see, because generally these injuries, you watch them for six weeks, and you find that the drum actually closes. But sometimes if it doesn't, after 3 months, then I have to do endoscopic tympanoplasty. Next slide. You can, next slide again. Again, I keep on wanting to use this thing, and it's not working properly. But I wanted to just show you, it's very sticky. So where you see that black arrow there, I don't know, I'm gonna have to go to this picture because I really wanna make my point. This here is the stapes, all right? And on here is the actual cochlea. That's the stapes flute plate. These are the other two ossicular chains, and that's your ear canal, and that's your drum. Any amount of pressure that goes around here, your weakest bone is this one. So you're going to get pressure directly into this area. You fracture this, and you ram this into the vestibule, and that's immediately when you get a dead ear. all right? So that's quite important. It also works with when you putting your foreign body, your I don't know, your sibalenkuku that you are using, or your earbud, same thing, you'll end up here, all right? Stop that. Okay, it's a very difficult surgery to fix this, and you end up with hearing loss. Next slide. Okay, I've already talked about the management. Of course, close observation, like I said, and then we'll also always do an audiogram. So if you've got audiology access, you can send those patients there, because it'll also give us an idea of actually that they're having a sensory or hearing loss. They are definitely going to have a conductive hearing loss, right? There's other things that you can do. I mean, when I was at Barra, we literally used to close those perforations with a paper patch, cigarette paper, believe it or not, we did it. And they will close. But now we don't do that anymore. Next slide. Again, from that, you get temporal bone fractures. Those can be blunt head injuries, sometimes gunshots, mostly, all right? But there's different types. So you've got two types. You get the longitudinal fracture and then the transverse fracture of the temporal bone. In the longitudinal fracture, those patients mostly will present with facial nerve paralysis, and then they also have an ossicular chain disruption. Very important for the casualty officer to first test for me and check if there's a facial nerve paralysis, I think Dr. Gani will agree with me that we struggle with testing facial nerve. For me to be able to know whether I need to explore that injury, I need to know that the facial nerve paralysis was immediate and it was complete, because that is an indication for me to do a mastectomy and explore it and give it a chance to recover. Those patients will have facial nerve paralysis and ossicular chain disruption, so that gives you immense amount of ossicular chain of conductive hearing loss. Again, also the transverse fracture, you get predominantly sensorineural hearing loss because you've got a fracture that actually goes through the otic capsule or the cochlea itself. So that patient will be very vertiginous, and they will have the facial nerve palsy as well. Next slide. Sometimes, in fact, those patients also get CSF leak most of the time. They get CSF leak from that area that I showed you of the stapes vestibule because of the fractures that happen in that area. Again, important to recognize your obvious signs when the patient arrives. Battle sign, that's the discoloration in the posterocular region, and then the raccoon eyes, and when you look in the ear, you will see that, can you check the next slide? Maybe there will be, okay, no, go back. You will see blood or hemotympanum, blood beyond the tympanic membrane. Sometimes you see a step deformity in the roof of the ear canal because that's the actual fracture, the transverse fracture. All right, so those patients need a CT scan. Next slide. Again, it's very, can't really explain here, but then this is actually a transverse fracture going across the otic capsule. Next slide. Acoustic trauma is what we spoke about, but also these are the traumas that can happen from the patients that work in the surrounding areas in the mines and where explosives are being used. Again, the machinery as well, that can also cause a lot of trauma. And the specific area that really gets injured is actually your hair cells. They're very sensitive, and they don't regenerate. So they experience that blast trauma, they're gone. So it's very important to also advise patients to be always using protective earwear. And those patients will present with sensorineural hearing loss acutely, tinnitus, and vertigo as well. All right. We give corticosteroids and diuretics for these patients because they get what we call otic hydrops, which is actually fluid retention because of the fractures of the intercochlear membranes. So you get changes in the fluid balance system in the inner ear. So you have to actually give them some diuretics to relieve that. Next slide. Again, the people that like to go somewhere in scuba diving, I get a lot of those patients, but they seem to be coming from abroad. Again, scuba diving, you can get otic barotrauma, all right? Those are the patients who are unable to ventilate their middle ear, when they're submerged. But also, You can get those patients that have been in a flight, and a flight was taking off and it's landing, they get sudden earache, then they're deaf, you know. And then when we look, they've got hemotympanum, and they've got very terrible pain, and they're dizzy, and they've got tinnitus. Next slide. And you see, this is a classic picture, okay? Sometimes because of the acute blood accumulation in the middle ear, I have to take those to theater to put a grommet and do a drainage. Now, don't go submerge yourself if you've got upper respiratory tract infection, because your stecking tube is edematous. It won't be able to compensate when you change pressure. Don't go on flights. My advice is that if you're feeling flu and you're going to take a flight, take some Iliadin with you. This is the only time I want you to use Iliadin. Next slide. Again, we've talked about that. You can use some topical nasal decongestants. Those work acutely. You can use Iliadin for this indication and some steroid nasally. And then for us, we take to theater to put a grommet. Next slide. That's just showing the grommet in the ear. Next slide. And then the big one here, which will drive also the neurologist, I think, crazy, is a patient who comes with suddenly waking up and they've lost their hearing and they don't know what happened. You know, and obviously sudden hearing loss has got a specific definition. It's a sensory neural hearing loss of more than 30 decibels over 3 contiguous frequencies within 3 days. Okay, so if you're looking at your audiogram. And those would have different etiologies: viral infections, vascular trauma, autoimmune, neurologic. All right. Next slide. Okay, go back. And so those are the patients that will come in immediately, and we do an MRI scan because also they tend to get vertebrobasilar strokes or bleeds, and they will present with a picture like this. Again, those are the patients that you would obviously do blood work and acutely put them on steroids to try and control and see if you can get all of these under control. But those patients can deteriorate if you don't manage particularly the autoimmune and the neurologic dysfunction. Typically, those are the patients also that would end up with the cochlear implant. Next slide. Again, we get to the middle ear infections. You know, we start easily with an acute otitis media that doesn't resolve, and eventually we get into a point where we are getting a perforation, right? Because the primary problem here, particularly, is the stecking tube dysfunction. And these patients come in with various issues in the nasal cavity, postnasal space messes. They've got middle ear infusion acutely, and then they start getting infected, and now you get increased pressure in the middle ear that you can't balance because also your stecking tube is dysfunctional. So what happens? You get a perforation, which is okay because now you're draining. But what we don't like is if you don't get a perforation, but you get problems of releasing pressure elsewhere in other areas, right? So you start getting pus going in other areas, subperiosteal abscess at the back of the ear. You get neck abscess, which we call a Citelli or basalt abscess. And you get facial nerve paralysis because of the increased pressure that actually happens from that. Next slide. So that then, you know, would present in the form of an acute mastocytitis. Again, most susceptible is the children, you know, but we don't see it a lot now because we're always giving antibiotics, so that gets it under control most of the time. Give the antibiotics, give a nasal spray as well, because the primary problem here, believe it or not, is the stecking tube. Okay, so if you at least have some treatment of that nasal cavity, you should be able to prevent the complications while we wait to see the patient. Next slide. Again, this is just a picture that would show acutely, there's pus here. I don't know if you can see, but anyway, this thing is not showing. There's pus, and then there's erythema at the back of the ear. Next slide. And you can also see the ear mush, you know, sort of bat ear pushed forwards and downward. That's a classic presentation with a discharge. But let me tell you, sometimes they don't present with a discharge. So what you see when you look in the ear is a bulging TM, or, you know, sometimes a dull TM, not bulging at all, but they've got that. That child has got a mastocytitis until proven otherwise. And most of the time in children like that, we would actually go to theater and drain, put a grommet. I wouldn't have to do a cortical mastectomy if they haven't got a perforation already. But giving them a stat of antibiotics and sending them urgently is advised. The next slide. This is just a slide just showing, what are the potential complications that you can get for an acute mastitis or acute middle ear infection that has complicated into a mastitis. Locally you can get just around posteriorly into this back of the area of the sigmoid sinus. You can get sigmoid sinus thrombosis, all right, and you can get just behind that is a cerebellum, which you can get a cerebellar abscess, and then you can get a meningitis from that extradural abscess and even a cerebral abscess, okay? Some of these patients can present with just a low GCS, and you don't know why, all right? They present to the physician with meningitis until you look in the ear and you see that it's actually the cause. Next slide. Okay, now we deal with the nasal cavity. Again, it's the same thing. The children can put the battery in the nose. Same thing. I've had a child that put a battery in the nose and that went up into, that fossa where you get the olfactory nerve, and that got destroyed as well, almost going into the brain. Very, very terrible thing. So I think it's definitely, you need to be sure what you see in the nose is not a battery, because that's an urgent referral, okay? Some of the children will present with epistaxis because now they've had this foreign body for a while. And what happens in the nose, then you get granulation tissue because it's trying to deal with the foreign body. But now granulation tissue is unstable tissue, so it'll start to bleed. So they actually present with epistaxis. And I think also the other thing would be the nasal discharge. Our prof Modi used to say, children in the nose, unilateral problems of the nose present with epistaxis, and adults, a nasal discharge, and in adults it would be nasopharyngeal cancer, and in children it would be a foreign body, and that's actually true. Next slide. So again, you need a good headlight, but my advice, don't do it, just refer it. Okay, this gets really out of hand, and to hold down the children and to take this out is going to end up bleeding. With the restless child, mucosal injuries, it's not a pretty picture, so just refer the child. Next slide. Oh, again, also, when a child comes to you with a nasal discharge, don't assume that it's sinusitis. It's actually a foreign body, so you need to refer the child. Okay, don't give them antibiotics and send them home. That is a disaster. Next slide. This was just a way of explaining. I think this is an old school way of removing foreign bodies. But I guess if you're stuck somewhere in the rurals and the ENT appointment is not happening, and I don't know what else is not happening. There's only one ENT in Zululand, by the way, so this is a possible scenario. So you can use those hooked instruments that you can find somewhere around in theater, or the basic sets. Those can work. Sometimes people have put in a catheter under and just blow it just behind the foreign body and pull it out. It's very difficult. So my advice with foreign bodies, just refer them. If the child can't blow their nose, just refer them. Because also they tend to dislodge posteriorly, and those can cause aspiration and an airway obstruction. Next slide. Nasal bone fracture, again, it's one of those fist fight things, or other types of traumas again. The important thing really here, number one, is checking if your patient has got nasal septum hematoma, because the septum tends to, in the next 12 hours, it will lose its blood supply if they've got a septal hematoma that is not addressed, because the septum derives its blood supply bilaterally from just one set of blood vessels. So if you've got an unaddressed septal hematoma, you actually get ischemia of the septum and it dies and you get nasal collapse. Again, the other thing would be CSF rhinorrhea in patients that have had blow fractures directly in the nasion. Next slide. That's just the deviation of the nasal, of the nose, also showing a slight cell deformity there. Also, these are the kind of patients that would get CSF leak because of the skull base fracture. Next slide. I think we're talking about that. Next slide. This is the septal hematoma or an abscess that you can get that needs immediate drainage in theater, basically. Next slide. That's an abscess that's being drained. Next slide. I don't do this anymore. I don't believe in packing noses and putting all sorts of things in the nose. If you make an incision on the septum and you drain the abscess, you can just put quilting sutures in there. And now I just pack with some gels that we have available, and that's that patients doesn't have to be inconvenienced by these nasal packs. Next slide. Again, what follows after that would be epistaxis. All right. Again, I always say that the first 10 causes of epistaxis is actually people putting fingers in their noses, because most of our patients have got allergic rhinitis and it's itchy. And what happens, your septum has got very prominent blood vessels. It gets very dry. You've got allergic rhinitis. It gets itchy. Those vessels break open as you scratch. So that becomes an emergency, you know. We're also living in an area where there's, you know, irritants, allergens that can lead us to be poking our noses all the time. Obviously, the foreign bodies and the tumors are also what we see in adults, you know. And also your hypertensive patients, you know, that present with uncontrolled hypertension can come with epistaxis. Next slide. I've already mentioned hypertension, and you get other diseases such as HT, all right? So those patients, again, have got very classic picture, prominent dilated blood vessels in the septum. They bleed unprovoked. They also have GIT issues, so they also will have Malina stools because they've got the same telangiectasia in the GIT system. Renal patients, and then drugs, you know, patients that snort in some cocaine can also have epistaxis. Next slide. Again, this is just a slide showing the blood supply to the septum, you know. Just of note is that you've got an anterior and posterior blood supply to the nose. So it's very imperative to determine whether you are having an anterior bleed or a posterior bleed, because if you're going to apply a gel or put a gel and only to find that your patient is now vomiting blood, it means you're actually dealing with the posterior bleeding, and especially maybe coming from the ethmoidal arteries or the sphenopalatine artery. So you will assess that patient, ask them to open their mouth and look at the back of their pharynx. If there's a waterfall there, it's a posterior bleed. Okay, so that will require more than just a pack. And also we need to discuss this offensive pack where, I mean, you know, this is the length of the nose here. So if we ask you to pack the nose, we mean put a pack this size all the way to the back. It mustn't be hanging in front of the nose. Next slide. All right, obviously there's basic things you can do. You know, pinch the nose. You know, patients can put ice in their mouths because those palatine arteries can vasoconstrict just with change in temperature and putting ice in the mouth. But really the key is to actually pack and get the ENT to see where the bleed is. Next slide. Next slide, please. All right, so you've got all of these things that you can use. I know now that in the Melomed casualties, there's Nasoheme. It's really nice, all right? If you have a patient that doesn't have a rapid bleed, because the issue is it can be washed off, I do encourage that. You can still use your adrenaline pack, but there are things called Merocells now. I don't know, I would just point it out. This is a Merocell here. It's quite long. So if I say the pack with that, it means you must put it in the nose, all right? But the key is this. Your nose is moving from the floor to the back like this. So your approach is literally going to be that, not that. Because then you're going to the brain and you're going to get stuck in the turbinates. So you need to, and it goes that way, it goes that long. So don't be afraid to pack the nose. Next slide. Again, we spoke about the anterior and the posterior blood supply. You've got your local anesthetics and decongestants, all right? Your BIP, which is what we would use before, all right? But a good old Surgicel from theater, you just cut it in the length. If you're wondering how much you should cut, you just put it on the tip of the patient to the ear. That's how long you should have your Surgicel. or your Surgicel, and that should help to pack that. You put the Surgicel and you mix your adrenaline with saline and you flush it, it expands and it stops the bleeding, and then you refer the patient. You can actually put a tampon, a good old tampon also works. Next slide. Sorry, that just shows a ribbon gauze with BIP. Next slide. This is just talking to the pack I was talking about. This is how you're supposed to pack the nose. If you're using the ribbon gauze, you see those layers, right? So what I do is I pack it while it's still outside the nose. I just create a thick pack and I will slide it in. Next slide. That's the spongy stent I was talking about. You can get from theater. Next slide. That's a Maricel. This is long. This entire thing must go into the nose. We mustn't find it, half of it hanging out. You'll also see that your patient will stop bleeding. Next slide. That's the approach. I wanted to just show that the movement would be going like that, not like that. Ne? Yeah. Next slide. The posterior nasal packing is quite difficult to pack to deal with because you can't really see. So if you're out there in the rurals, just put a balloon catheter now. That's the urine catheter. I do advise that you put your, what's that thing you put? KY jelly. you again, the same movement from the floor, right? Generally what I do is I will advance it and ask the patient to open their mouth, and I see. If I see it dangling at the back of the uvula, then I pull just so that you don't see it, and you burst your catheter and you just put water and you feel that balloon. So it will sit at the back and it will block the sphenopalatine arteries because those are responsible for the posterior bleed. And then you refer the patient. Next slide. Because generally, this is what I was explaining, just that movement. I don't really, because now you're going to have a gagging patient, it's too much, all right? So when you advance it, I see it hanging here. I don't let it come to the mouth. That patient is already gagging and splitting blood. To this level, you pull it slightly and you burst your bubble, and it sits nicely. I've never had to take it out of the mouth like that. It must be uncomfortable. And they're gagging and they're bleeding and it's a mess. Next slide. That's some of the balloon catheters. I know Smith & Nephew has got something that looks like that, but next slide. It should ideally sit like that. So you've got an anterior pack and you've got a posterior pack, and you've addressed both parts of the bleeding. Next slide. Again, the one thing now that we deal with a lot here is also complicated sinusitis, which is an acute infection and inflammation of the paranasal sinuses, all right? The problem is that you do end up with orbital complications and also intracranial complications. Next slide. Again, we do have a classification for this, okay, which basically helps us and it guides us how severe that would be. And stage one really, the stage one really would be inflammatory edema and periorbital cellulitis, and already that patient that has periorbital cellulitis with the nasal obstruction, nasal discharge, fever, acutely nasally obstructed, that's already an indication to be admitting that patient and do a CT scan to exclude the rest of what stage is it. So stage 2 would be orbital cellulitis, then subperostal abscesses, orbital abscesses, and then eventually cavernous sinus thrombosis. We don't want to get to that stage. Next slide. Commonest bugs, obviously, strep pneumonias, and you really would deal that with broad spectrum antibiotics. Also, I do advise that that's the second time you would use Iliadin because you decongest the drainage system acutely, and then some steroids. But that patient would need a CT and probably theater. Next slide. It looks like that. Okay, I've got 2 minutes. Next slide. Again, obviously the complications would be, intraorbital collection with blindness. Also, that's something we want to avoid, and obviously visual loss. Next slide. Next slide. Still that. This here is very important. I've had a patient coming across with this complication. This is a Potts-Puffy tumor where you get pus that collects in the frontal sinus, and then you also get erosion of the frontal table and posterior, and that means that now you've got an epidural collection and sometimes a direct intracranial collection. But I've had a patient who had an IND, an IND in this area, and I was looking at the brain when I opened. So no, please, no INDs, CT scan directly, because these are drained intranasally, endoscopically in theater. Next slide. Again, I've explained what it is. We call it a Potts-Puffy tumor. Next slide. So that patient would need a CT scan, antibiotics, and basically functional endoscopic sinus surgery. Next slide. That's just a CT showing, how the intraorbital collection would be like. I just sent there. Next slide. Yeah, so they can present with all of these things. We don't want to get to these complications really. Cavernous sinus thrombosis, because they can also have blindness from this, meningitis, and all the abscesses. So that's an urgent referral. Sometimes they can present with seizures and the low GCS from the collection. Next slide. Next slide. Next slide. Just a quick one with the throat. Next slide, because I've got 1 minute. This is, again, a problem of aspiration. But I find this very interesting that we're seeing a lot of adults with fish bones in the larynx. I don't know why people are eating fish like that. But this is a problem. Next slide. Again, sudden cough, wheezing, stridor, children as well that run around. I mean, the one thing I remember when I was still a registrar at Bara, the children were from a party and they had these things, and I don't know how they are dislodged and they aspirated it. And then I get called to casualty and all I could hear was a boo, boo, boo. And then I arrived there, the child is we can hear the boo, but where's the thing, and the sets are 60. So we ran to theater and we found it sitting right at the larynx, right, going on and on like that. So I don't like those things. Don't buy those party things. Next slide. Again, if it gets to the stage of you doing the chest x-ray, that's really, I don't know what. I've never done a chest x-ray for a referring body aspiration because it's always urgent, right? So we go straight to theater, but hyperinflation because, one side is blocked and you have to go to a bronch sometimes. Next slide. Swallowed foreign bodies, again here, the most important one is still those batteries that we worry about because they will cause chemical perforations and then mediastinitis. Next slide. That's the fish from an adult, fish bone from an adult. I don't know. Stop that. Next. Okay, again, the most important thing here is that you can get a foreign body lodged in the cricopharyngeus, right? And that would create a stridor. And we don't know whether this thing is in the esophagus or in the larynx. But actually, the cricopharyngeus goes into a spasm and obstructs the airway. And most of the time, you actually end up with the stridor from that. But when you go and look in the theater, it's in the esophagus. Perforation is also a risk there. Next slide. Again, this is also a child swallowed a 5-franc coin. That is always bringing a debate whether this is a general surgery, ENT, or cardiothoracics. Any of us can do it, guys, actually. Next slide. All right, so again, airway obstruction from neonates and newly born children for the pediatricians. This is very difficult. These patients always need ICU management. They always need some flexible scope and a direct laryngoscopy. Again, these present immediately at birth. Next slide. Yeah, so in children, the infections are mostly the laryngotracheobronchitis, epiglottitis, and retropharyngeal abscess, and of note, respiratory papilloma. We see a lot of laryngeal papilloma and patients presenting with a stridor. Next slide. Adults, laryngeal cancer, very common. See it a lot in Ngolezane, and those patients end up with an awake tracheostomy because you can't put a tube anywhere. So we take them to theater for an awake tracheostomy. And the other thing is the laryngeal trauma. Patients that get slit their throats. I had another patient who said he was running at night and he didn't realize that there's a washing line, and he ran through a washing line, and he had a blunt trauma. All you could see was red there, but he had stridor. And when we got there, he had fracture of the actual thyroid cartilage and the disruption of the vocal cords, so that's quite important. Next slide. This is also important. Now, the deep neck infection, starting as epiglottitis, or sometimes patients with what we call Ludwig's angina or flow of mouth infections. The important thing about these abscesses and infections is that you've got other deep neck space tissues and facial planes that would encourage a spread of infection into the chest. So you actually want to get those patients transferred urgently because they can get mediastinitis. So those complicate in that manner. Next slide. Peritonsil abscess is one of them. Okay, so generally you definitely want to refer that patient. I was going to demonstrate about the drainage. I don't have time. Next slide. That patient, peritonsil abscess, is an immediate referral because, again, the risk of spread to the chest. Next slide. That just shows the abscess there in the parapharyngeal space. Next slide. Again, those patients need full blood counts, antibiotics, IV fluids, needle aspiration or IND. I know it's always a problem to aspirate because they've also got trismus because of the irritation of the pharyngobasilar fascia. Hot tonsillectomy is when you are actually having an active abscess causing an airway obstruction, right? We don't want to do tonsillectomies in the presence of infection, but you end up having to address that if a patient is actually having spread to the chest. Next. Ludwig's angina. This is always a fight between us and the maxillofacial. This patient belongs to the maxillofacial. It's always a dental infection. I will only see the patient if I have to secure the airway. Okay, next slide. That it looks like that. Okay, and sometimes, again, they can have a deviated trachea, intrathoracic collection. It's also quite a bad infection to have. Next slide. Next slide. Again, I think this is this is maxillofacials that would do this kind of drainage just to relieve pressure, because sometimes it's like cellulitic infection and it's pressure that's actually causing all of this airway obstruction, and there's no actual collection. So it's always a problem. Next slide. Epiglottitis, I think we've touched a bit on it. These are small children. Pediatricians usually know how to manage this very well. Next slide. I think I'm done. Am I? Next slide. Okay. I think I am losing my breath. I think it's between me saying next slide is stealing 1 minute. Thank you very much. Please do. I know that it's always a pain to refer to ENT, but there's actually one ENT service in 2.7 million people. So we will definitely take your concerns, but Ngolezane is available. ENT clinic is on Tuesday, Wednesday, Thursday, but Tuesday is the ear clinic, Wednesday is head and neck, and Friday is rhinology and general clinic, and Monday and Thursday is our theater. Okay, thank you.